Many thanks. In this happy night, happy August night, I'm so grateful for my icon and role model, Dr. Saad Mahdi, who innovate and manage one of the biggest worldwide e-learning electronic learning program, MEGA. MEGA is a name and a case. Firstly, I am honored to introduce Prof. Lalit Gupta, Associate Professor of Medicine of Anaesthesia Critical Care in Maulana Azad College of Medicine, will stream one of the challenging topic in critical care, which is organophosphorus compound. What is new? What is the conflict issue in this subject? Prof. Lalit will clarify every point. Okay, Dr. Lalit.
Visible to everyone. A very good evening to everyone. Today we are going to discuss a very important topic of critical care, the organophosphorus poisoning. What I have decided for today's evening that I will be discussing it with a real life incident, a case challenge for everyone, and we will discuss the salient feature of that case along with the what is new, what should be done, what are the evidences for the treatment, and what are the differential diagnoses that one should know while we are dealing with a case of organophosphorus poisoning. So let me start. Uh, Suddenly, at one night, a 25-year-old female with no comorbidities was found lying unconscious at her home at around 12:30 a.m. There was frothing from the mouth, and a bottle containing chlorophyrifos was found by her side. She was taken to a nearby hospital emergency where she was intubated since she was unconscious and not responding to commands, and received other emergency treatment in form of gastric lavage, IV atropine, and IV fluids. Detail of treatment receipts were not available at that time because in the early morning she was referred to a higher emergency center in the intubated state for further management. The histories, the physical examinations, and other findings were confirmed from the attendant, and it was found that there was some family conflict. Because of that, she took some poisonous substance. It was a pesticide which was kept as they were belongs to a farmer. Medical legal formalities had been done at the previous hospital because it was a case of the suicidal. The physical examination on the morning at 11 a.m. where down were taken were patient was intubated. She was on ventilator. The oral secretions were abundant and it was fulfilling the endotracheal tube. The heart rate, however, was just 92 per minute with BP of 150 by 79 millimeter of mercury, right arm supine position. The saturation she was maintaining of 98 on ventilator with on FiO2 of 0.8 to zero point 0.9. Chest was bilateral clear. There was no cracks. The minimal cracks were present at both the bases. The CVS S1, S2 heart sounds were normal without any audible murmur or muffling of the heart sounds. Abdomen was soft, no guarding. The CNS patient was arousable. At that time, his GCS was E3VTM5, that is around 80. The pupils were reacting to the light bilateral and it was around 4 millimeter in diameter. So with these findings and associated history and provisional diagnosis of organophosphorus compound poisoning was made. In our case, there was a substantial bottle, as I shown you in the first slide, was found near her. So it was suspected that it was a case of the organophosphorus poisoning. Treatment included gastric lavage, IV atropine, IV fluids, and antibiotic cover, along with the supportive care was immediately started and was carried on. The atropine infusion was started at 0.5 milligram per hour and later increased as per the demand. The relevant investigations were all sent and which were LFT, KFTs and hemograms were within normal limit. With the above mentioned treatment, patient's general condition improved and she was extubated after 36 hours. That is on the evening of second day. Patient was managed conservatively in ICU for the next 2 days when she again started complaining of generalized weakness. Means patient was having the features again. She also developed the facial twitching with ptosis for which a neurological consultation was done. And a pseudocholinesterase level was sent initially, which reported to be less than 1 international units. She was again started on IV infusion atropine at the rate of 3 milligram per hour and praludioxime at the rate of 200 milligram per hour. GCS improved over next 6 hours. She became conscious, started responding, hemodynamically stable, with power of 4 by 5 in all the limbs. Treatment was continued and investigations sent, which were within normal limits. In view of prolonged ventilation, patient was tracheostomized and gradually weaned from the ventilator. She developed agitated behavior on vent, for which she responded to the reduction in dose of atropine. However, when the dose of the atropine was reduced immediately as a supplemental injection glycopyrrolate was started, injection PAM paralleloxime was stopped after adequate recovery of muscle weakness and atropine tapered gradually. Her general condition improved gradually and she was shifted out of the ICU after exactly 12 days. She was conscious, oriented, hemodynamically stable, had good neck holding with adequate muscle power in all the four limbs. She was taking normal diet orally. She was vocalizing well with cup deflated of the tracheostomy tube and had minimal tracheal secretion. Over the next 2 days, with consultation of the ENT persons, trachea was decannulated. Post decannulation, she was maintained very well. However, she was discharged to home after a laborious 25 days of hospitalization, but in a very stable condition and with a happy mind. So, I just presented a case of typical OP poisoning where patient was presented to our ICU and she was sick. So, coming to what type of poison she could have taken. Now, I am giving a brief classification of the pesticides which are found in all the hounds. One is the natural and others are the synthetics. The natural beings the microbials like bacillus, plant incorporated like BT cotton and corn, and plant extract like essential oils. While biochemicals like insect sex, pheromones, scented plant extracts. See, remember the natural biopesticides are not so much harmful as were the synthetic one. The synthetic one were the carbamates, organochlorine, pyrethroid, and organophosphates, which includes malathion, diazinon, parathion, the nerve gases. So our DD is from the synthetic chemicals carbamate, organochlorines, and pyrethroid in such a case. However, we will be discussing in detail the organophosphate and later we will come to the differential diagnosis. So organophosphate compounds. These are the pesticides, herbicides, and chemical warfare agents like the nerve gases. OP poisoning in intoxication is very not so common, but at least 3 million per year worldwide, with approximately 3 lakhs death is reported because of this poison. Most of the pesticide poisoning and subsequent death occurs in developing countries following a deliberate self-ingestion. So coming to the physiology and the pharmacokinetics and dynamics of OP compounds, they consist of a central phosphorus molecule with two basic groups, B and B dash, and another bond of either with oxygen or sulfur. The fourth bond is either alkyl or aryl group, so they are either alkyl or aryl phosphates. Now coming to the classification, they are, as I told you, they are the nerve agents. One of you is very famous sarin gas that you must have heard many times. The G agents and the V agents like VX and VE, which are very neurotoxic. While the insecticides are either the methyl components or the ethyl component. Out of the methyl components, most important is malathion and panthion and dichloro. While in the diethyl, they are the diazinon and parathion, which are easily available as a pesticide in most of the pharma houses. Coming to the nerve agents, nerve gases are highly potent synthetic agents. G agents like sarin gas, they are the volatile and disappear rapidly after use. And now these are at present the chemical warfare. Although these are banned to use by WHO and international community, however, the reported uses of sarin gas are held in many times. And these are so harmful that they disappear
Auxiliary.
very easily.
FM radio. Bluetooth connected.
While the V agents are contact poisons unless aerosolized and contaminated ground for weeks or months. They are related to OP pesticides but have much higher acute toxicity. So I would like to tell you a normal physiology of the how they work. What happens? The whole game is of the acetylcholine. The synthesis of acetylcholine, which is becomes with the help of the choline and acetyl by the acetyl coenzyme A. in the presence of the sodium ions, and this point is inhibited by hemicolinium acid, toxic. Once the acetylcholine is made, it is uptaked into the vesicles of acetylcholine and degraded in the vesicles, and it released at this neuromuscular junction. This is the synaptic junction from where it works. Now, all the organophosphates and other carbamates, they work at this junction only when choline is dissociated from acetylcholine, and this degradation of acetylcholine is by the acetyl coenzyme A esterase is prevented by organophosphates. So if you see, when the organophosphates, they come and act at the active site of acetylcholine esterase, they makes a covalent bond which becomes inactive, and this becomes acid. Means it cannot dissociate till it is completely degraded by the chemical reaction of its own because of aging, and it becomes irreversibly inactive, leading to the sustained uh, signaling at the synaptic junction, and hence the convulsions and other toxic side effects. Now, what happens to this acetyl coenzyme A and organophosphate complex? So, if you see clearly, while I have shown a few examples of the serine gas, where the rate of aging is unique and it can occur over minutes to day depending on the agent. The serine gas becomes very fastly, it disappears, the patient dies within minutes, and there is no use after that. While if you see the PAM, the parallel oximes, they act and they prevent this bonding of this OP with this acetylcholine, and hence it prevents the aging. So the aging is prevented and acetylcholine esterase enzyme is reproduced with the help of the PAM. But we will be discussing it more. The spontaneous reactivation of enzyme is the one method by which it can work, and we can decrease the side effects. This occurs at a very slow rate, much slower than the enzyme inhibition, and requires even hours to days. The rate depends on the type of the organophosphate compound. The spontaneous reactivation time for dimethyl and ethyl compounds may vary from zero point 0.7 hours, that is half hour to 1 hour, and then up to 31 hours. Means the patient may become in the same comatose stage without any treatment, and if not respiration is supported, may die within 24 hours. This reactivation can be hastened by the reagents like oximes. While the other fate is the aging. With time, the enzyme's OP complex loses one alkyl group, making it no longer responsive to reactivating agents. However, this depends on the pH, temperature, and type of the organophosphate poison. Dimethyl and diethyl compounds have been shown to be aging of 3.7 to 33 hours respectively. While, as I told you, the nerve agents, the chemical warfare, they undergo aging within minutes. What happens after that? Once the poison has reached to the acetylcholine receptors and their presynaptic junction, then the clinical manifestations arise. The onset, severity, and duration of poisoning depends on one, the route of exposure in the case of like nerve gases, or the agent involved lipophilic, like the parathion, malathion types. Subsequential triphasic illness is more likely to follow OP intoxication in certain compounds, leading to acute cholinergic crisis, intermediate syndrome, or delayed polyneuropathy, called as OPDAN. We will be discussing one by one. If you see the acute cholinergic syndrome, it compounds consists of the three type of receptor effects as per the receptors: the muscarine receptor, muscarine effect; nicotinic receptors, the nicotinic effect; and the CNS effects. While the muscarine effects are important of meiosis, bronchoarea, bronchospasm, salivation, lacrimation, abdominal pain, and bradycardia, the nicotinic effects causes the muscles hyperfasciculations and reflexia, leading to seizures, and hypercontraction, leading to cardiac arrest. The flaccidal muscle weakness with reduced tendon reflexes. And CNS effect may lead from headache, dizziness, drowsiness, confusion, fits, coma, central respiratory depression, which may require the intubation immediately. The treatment, I will be discussing it later on. So if you see, it is a very easy to remember the symptoms of OP poisoning. Just remember which is the most common symptom is the slug, that is the dust, the dirt. The salivation, as for salivation, L for lacrimation, U for urination, D for diarrhea, G for abdominal cramps like the GI upsets, and E for the vomiting or emesis. This is the simple main mnemonic which you can remember. while you are dealing with the OP poisoning. If you find that the sequence is of the slug, you can definitely go for the OP poisoning treatment. The other neurological, as I told you, it is the type 1 paralysis, type 2 paralysis, and type 3 paralysis. The type 2 paralysis happens within 24 to 48 hours, and its treatment is only atropine because it only involves the fasciculations, cramps, and weakness. And type 2, which is the very common type of paralysis, it happens 2 to 4 days after resolution of acute cholinergic symptom. That is, it is the intermediate type of paralysis. It manifests as respiratory distress due to neuromuscular transmission defects. The weakness of proximal limb muscles, neck flexors, respiratory muscles, and cranial muscle palsy are the common manifestations. The deaths are reported and it never responds to atropine and oximes. The treatment is symptomatic. Similarly, the final treatment or final type of paralysis is the type 3. It is the delayed type of paralysis after the OP poisoning. That's why the patients are sometimes kept for 28 days under observation. It causes the paralysis of lower extremities, foot drop, numbness, paresthesia, sensory symptoms, and paralysis may persist for months. It never responds to atropine and oximes. Again, patient may require the respiratory support as well as the neuro support in such cases. A scale has been developed quite long back to assess the severity in OP poison intoxication. This is called as the POP scale, which involves the pupillary size, the respiratory rate, the heart rate, the fasciculations, level of consciousness, and the seizures. Means if you see, it includes the every vital organ from the eyes and brain to the heart and respirations and fasciculation in form of muscle. It has a grading of 0 to 3 mild to 8 to 11 severe poisoning. And you know, this grading is very important because the mild score means the mortality is very low, 3.8%. However, the severe score of POP means the mortality is 33.3%. That means the patient is very one-third has the only chances of survival. Coming to the acute cholinergic crisis, which is sometimes seen when a large amount of poison is congested, the effects more are on the CNS than nicotinic and than muscarine. The heart rate and BP finding in such a case may be misleading, as in our case it was like when the heart rate was only 92 and pulse rate was BP was only 151/97. So it can be misleading because in that case the CNS symptoms are very much pronounced when the patient becomes unconscious. In severe cases only poisoning, you will find the tachycardia and hypertension. Patients may also develop the acute pancreatitis, hypo or hyperglycemic episodes, and AKI during the treatment phase. The prognosis in such case depends, as I told you, dose, toxicity, the half-life, and aging of the compound. And more important, the alkyl group, that is the methyl or diethyl, which is attached with the acetylcholine enzyme. The time of death may range from within few minutes to 24 hours, depending on dose, route, agent, and availability of nearby treatment. Respiratory failure, hypotensions are the immediate cause of death in acute stages. Now I come to the intermediate type of syndrome. It is a distinct clinical entity seen in around 10 to 50% of cases of acute poisoning and develops after 48 to 96 hours after ingestion, as it was in our case. Risk factor for developing IMS includes highly lipid soluble compounds and inadequate treatment of the acute phase, like inadequate dosing of oxides. The onset is rapid with progression of muscles from the eye muscles to the neck to proximal limb respiratory muscles, and over 24 hours patient goes on the ventilator. Just like in our case when we extubated and we have to re-intubate our patient. The increasing respiratory difficulty causes anxiety, sweating, and use of the accessory muscles. The proposed mechanism includes the persistent inhibition of acute cholinesterase enzyme leading to functional paralysis at neuromuscular junction. The downregulation of receptors, the muscle necrosis, and oxidative free radical damage to the NM receptor. The most disastrous complication is OP-induced delayed neuropathy, for which if the patient is survived, he may have suffered for a long time. Although it is a rare delayed neurotoxic effect, which happens around 1 to 5 weeks after severe cholinesterase inhibitor toxicity, and it happens due to the inhibition of neuropathy target esterase enzymes in nervous tissue. It is more likely with OP compound like chlorothyreos and malathion. Its clinical feature includes cramping muscle pain in the legs with numbness in the distal upper and lower limbs, acute weakness leading to shuffling gait with foot and wrist drop. Examination only relieves the decreased tendon reflex and flexing muscles. Later, mild pyramidal tract signals may develop and patient may have abnormal or swinging gait. The diagnosis of OP poisoning is very important. It is aided by finding of possible poison container in the vicinity of the patient. However, in the many cases, it may not be possible to find any source. In that case, analytic identification of the opioid organophosphate in gastric aspirate or body fluids may give some evidence of exposure. Even if you are not convinced what type of poison is this, 1 milligram IV atropine can be safely given. Failure of anticholinergic effect should raise suspicion for anticholinesterase poisoning. Means you have given the atropine and within 1 minute, if your heart rate has not increased to the desirable level, it means there are high chances of OP poisoning. For this, we have the diagnosis now at the biochemical in form of cholinesterase activity and chemical energy. Estimation of cholinesterase activities involves both red cell and plasma enzymes. While the normal value is 77 to 142 and 41 to 140, it is reduced to 22 to 88% in most of the cases. If you remember, in our case, it was just 1. So pseudocholinesterase levels are more sensitive and falls rapidly than red cell. True cholinesterase activity is better and diagnostic, and prognosis value depends on the level of cholinesterase activity. While chemical, as I told you, by the gas chromatography or liquid chromatography, it can be found in the blood as well as gastric aspirates. Coming to the most important part is the treatment. The acute crisis depends on the decontamination and supportive, the reversal, the correction, and type of the finding the type of the OP compound to decrease the severity of the symptoms. A simple is decontamination, presenting patient with an ingestion, patient is conscious, give an active gastric lavage with charcoal, or if patient is unconscious, secure the airway by intubation, gastric lavage with charcoal. Presenting up more than 2 hours, patient is conscious, role of activated charcoal is doubtful and sometimes it is not used. If altered unconsciousness, secure the airway. So the golden rule is that if the patient is going unconscious anytime, as was in our case, secure the airway first and remove the patient from the vicinity of the poison. The specific antidote for muscarine effects, it has no effect on nicotine, is the atropine. The dose is 1.8 to 3 milligram bolus dose, doubled every 5 minutes until atropinized. Then 20 to 30% dose is needed for maintenance, given as infusion per hour. The atropinized when the pupils are dilated and temperature is increased, you can find out that the response is people have found that atropine versus glycopyrrolate, there was a study in the critical care medicine 1919, they found it gives the equivalent outcomes. While atropine versus atropine and oximes combination is less beneficial with respect to the death and ventilation. So even if you are adding the oximes, you may not get the same effect as you are getting with the atropine, and sometimes it may become worse. There was a study where the organophosphate poisoning, the dose of atropine was measured in the Bangladesh. They found the atropine 1 milligram. If rapid atropinization occurs, poisoning may be mild. And if the atropinization does not occur, treatment according to the treatment group. The sign of atropinization include clear chest, heart rate, as I told you, more than pupils no longer pinpoint means they are dilated. If the patient responds to atropine, he may be observed for 24 to 48 hours and may be discharged. While if doesn't happen, then patient may have to be further evaluated for further poison. Again, they found another study was done to find out the atropine bolus versus the infusion. And they found that continuous atropine plus palidoxime until symptomatic improvement and recovery is not above than the atropine bolus or the infusion. They found that 2 to 5 milligram of initial atropine every 10 to 5 minutes when given can reduce the life, save the life of the patient and reduce the OP side effects. While similarly, if they are giving it is by infusion, then they sometimes have to add the injections of the infusion of the palidoxime in the same group to save the patient. So what are the oximes? As I told you, they are the for use for the reactivation of the organophosphate bound to the acetylcholine esterase. They are of the two types, the PAM, the palidoxime and obidoxime. they reverse both the muscarine and nicotinic effect. Remember, atropine only reverses the muscarine, not the nicotinic effect. WHO has recommended a dose of 30 milligram per kg IV bolus over 30 minutes, followed by continuous infusion of 8 milligram per kg per hour. While the other for palidoxime, it is 1 gram bolus in 30 minutes and infusion in 0.5 gram. And obidoxime, it is 0.25 milligram bolus, then infusion of 0.75 gram. The adverse effects, dizziness, headaches are sometimes there. But again, there was a Cochrane database review. They found that only one RCT compared the WHO compound, and it has found that WHO recommended regimen bolus followed by 8 milligram is not supported and it is not required. That's why the most of the practice in modern clinical anesthesia and ICU, they give the bolus of the oxygens followed by the infusion and not the 30 milligram bolus. As I told you, sometimes the patient has the intermediate symptom, which for this patient may require the ventilatory support. For seizures, the diazepam, the parenteral nutrition, and unless the opioid neurological symptom develops, the recovery from IMS is complete and adequate. And no specific therapeutic measures are needed. Regular physiotherapy is just what is all needed, and substantial functional recovery after 1 to 2 hours. Why it is important? So if you see medico-legal, what is the important? If it is suicidal, alone or mixed with some other. Homicidal, it is rare to find due strong smell and bad taste. Patient is unable to take or patient will not take it. Accidental, it has been found the Kerala food tragedy of 1958 and Bihar midway meal tragedy of 2013. Warfare, you know it very well, sarin use. Organophosphate compound resist putrefaction in the body. They can be detected in viscera, blood, and hair for sometimes even after the death. And they are the restricted use pesticide because of high potential of causing significant human and environmental hazard. Sometimes patients go for postmortem and the findings are that every organ is congested from brain, conjunctiva, face, mouth is with froth, heart is petechial hemorrhages, stomach like content smell of the kerosene, and lungs are congested and edematous. The summary is that all internal organs are congested with the acute OP poisoning. I told you that there may be some, what are the various diagnoses, the differential organisms. One is the carbamates. They are reversible acetylcholinesterase inhibitors. The mechanism is they are the reversible actions, so they are the less toxic. Carbamylate, the serine moiety of the active site of acetylcholinesterase, but this is reversible. The fatal dose is 10 to 30 grams for carbofuran and fatal period is 2 to 6 hours. This is the one differential diagnosis, and the another one most important is the organochloride. Organochlorines is they are the chlorinated, not the alkaline. They are the chlorinated and they are lipophilic, adipocyte accumulated poisons. The most common example is DDT, which is used the BDT, BSC, and Linden, which are most commonly used for the farming. The symptoms are same like nausea, vomiting, abdominal pain, cough, dyspnea, hoarseness, headache, giddiness, but patients rarely go to the coma, convulsions, and death. The dose is 5 to 6 grams and fatal period is 12 to 24. No specific antidote is possible for organochlorines. Only gastric lavage and activated charcoal is what all needed. Polystyramine can be used. It is a bile acid binding resin that can be given orally to increase the fecal excretion of such compounds. So in the end, I would say if you found a case of the organophosphate, always remember the two differential diagnoses of carbamate and organochlorines. Just give the atropine. If the heart rate increases, it means your patient is responding. And if it is not responding, it means the high chances of organophosphate poisoning is there. And always remember, organophosphate are poison. Do not take them. With this, I thanks and I end my presentation. Thank you so much. Thank you, everyone.
Thank you, Prof. Lalit. Thank you for this fascinating lecture, highly presentative, highly informative. Many thanks,
Thank you,
Prof. Please, from my side, I have a question as regard the PAM, the anti-nicotinic receptor.
Yes, ma'am.
What the optimum time to give it for your patient, please?
So as I shown you, it are the oxime. The WHO has initially told that 30 milligram per kg of bolus followed by 8 milligram per kg. but most of the RCTs have found that they are not useful. So oximes in the form of pallid oximes, when given at the rate of 0.5 milligram per kg initial and followed by the bolus, they are the more potent for the nicotinic receptors only. So remember, if your patient is having the nicotinic symptom, then only oximes to be used. If only muscarine receptors are involved, like the sludge that I told you, then only atropine to be used, because atropine plus oximes do not sometimes have the good outcome. The patient may have a mortality.
If we have found some papers tell that after 48 hours is the optimum, sir. 48 hours after
yeah.
the poisoning.
The most common manifestation of stopping the palm is whenever the neurological symptoms are disappear. So don't go by the book, just go by the clinical symptoms. If you find the seizures have stopped, if you find the muscle weakness is not there, and ptosis, this is the most common symptom because the ocular symptoms are the first to come and first to go. If they have gone, then stop the PEM. And they usually goes if the patient is not going in the intermediate state, then they subside by 48 hours.
Okay. Yes, sir. Please, as regard the glycopyrrolate, when you can substitute it for atropine or continue by it for some patient, as regard the morbidity of coincidence disease, glycopyrrolate, you can complete the treatment.
So, ma'am, there are not much trial RCTs on the glycopyrrolate comparing the atropine. The only RCT in the 1919 which has been done has shown that it has the equal efficacy. And the only indication of using the glycopyrrolate is that when the patient is atropinized and is having the persistence high harder, the patient is make on the atropine toxicity, like the very much high increase in the temperature of 103 or 104 or 106, like the rat beet like syndrome. So in that case, you may substitute, decrease the dose of the atropine for some time with the glycopyrrolate. And once the patient has become normal, then you have to restart the atropine, because RCTs are not there. So I will not advocate giving the glycopyrrolate for a very long time, but yes, for substitution for a very short duration.
Okay, very nice. So yes, this is my last question. As regard the delayed symptoms as neuropathy and the muscle weakness to occur maybe 4 weeks after the poisoning, this is irreversible changes or maybe reversible after that?
These are reversible. Mostly the patients manifest, they feel them for the 28 days. But in the few cases, they have been found to up to the 3 months. That's why the supportive therapy inform the respiratory, like spirometry for the respiratory muscles strengthened, and the physiotherapy for the other peripheral and visceral muscles. It has been advised that patient may go on these, and the patient has been taught to deal with the patient. Sometimes feel the patient is not able to take the respiration, he should immediately respond and back to the their nearby health facility, because they are the temporary symptom, but they sometimes can land you in a difficult situation. But they are completely reversible after 28 days.
Okay, my last comment, I'm so sorry. What about the red blood cells, the cholinesterase? It is of a prognostic and diagnostic value or diagnostic value only?
They have both diagnostic as well as the therapeutic values, because diagnosis, that actually what happens if the patient has taken the large amount of the OP, then the cholinesterase enzymes are for less than 1%, and in that case the mortality is very high. But if the values, their enzymes are not reduced to the substantial level, then there are very high chances that within 24 hours patient may recover. So they not only help in the diagnosis but also dictate the treatment.
Okay, thank you, Prof.
Thank you.
Thank you.
Thank you, ma'am. Thank you. Anyone else?
Okay, thank you. Goodbye.